All right. So welcome everyone, and it's a pleasure to be finishing this IAP course on mental health AI and minority populations. And all of you have been doing a great work so far. We had final presentations yesterday, and it's impressive how a group of MIT undergrads can reach this level of um, progress in 3 weeks of work, which was really impressive. And we wanted to end this IAP course with a very special guest, which is Professor Thomas Insel. He has a very big CV, which I don't want to read, but all you have to know is that he's a leader in the mental health and technology space, and he has experience working both in academia, leading efforts in the National Institute of Mental Health, and also leading efforts in industry by going into Google Verily and then starting some startups as well. So he has both points of view. And we felt that it was great to host him for you to have a great overview of what's happening and what are the opportunities and where we might go. And the whole point of this talk is for you to inspire you to continue this important topic beyond IAP. And as we mentioned yesterday, there is several tracks you can go, right? So there is several professors at MIT doing this kind of work. So we are going to support you any way you want to go. But as I said yesterday as well, we need many bright minds working on this because it's a very challenging project topic, and also we need solutions that are effective, science-based. But anyhow, so the floor is yours, Tom.
Okay, thank you. Elmar, I'm going to start right where you finished because I think you're exactly right. We do need a lot of smart people thinking about innovative solutions in this space. And just to introduce myself, like Mercedes, I've spent most of my career as a bench scientist, a molecular scientist working in neuroscience. So I spent not more than 2 decades trying to sequence receptors and insert them into cells and get them to do really cool things related to behavior to try to understand complex behavior and its cellular and molecular basis. But over the last couple of decades, I've been thinking about a very different set of problems, which is how do we bend the curve for people with mental illness? I guess I'd always thought that that molecular cellular work would kind of open the door and answer the question. I think it will, but probably not in my lifetime. So, with as my age got older, my patients got uh, smaller, and I began to think more about what can we do in the near term. And so, just to kind of introduce what I want to talk about, it's much more kind of about a call to action for a social movement than it is about a particular um, AI algorithm or new discovery, although I think all of that is going to be an important piece of it. So if I can, let me share my screen. Let's see if I'll be able to do that. If I can't, we might have a problem. I think I can. Um, let's see here. Oh, we don't want that, but we do want this. And hopefully, can you see the slides, mental health innovation?
No, we
Cannot.
see your Gmail.
Okay, so
Yeah.
I'll fix that. Hold on a sec. Just do this one more time and then I think we can get it to work. All right. Bear with me a sec. Okay, here we go. Now, any better? Can you see the slides? Okay, good. So let me take you through this. We'll do it pretty quickly and then really want to save most of the time for conversation. But fundamentally, I want to talk about three areas. I want to actually, and you've probably heard some of this before, but I want to define the problem. At least in engineering, that's where you always want to start. It's getting a really clear idea of what the problem is, and then to think about what are the solutions we have now. But I want to, at the end of this, kind of widen the lens to talk about this concept of recovery, which I think is super interesting. Um, I used to work a lot with people in the Pentagon, and they always had this thing where if you do a presentation, they'd say, well, we don't have a lot of time. Give us the bottom line up front or bluff. First time I heard that, I had no idea what they were talking about. They said, what's the bluff? But it's sometimes a good thing to think about. So my bottom line here is that we're going to talk about behavioral health as a public health crisis because that's really what it looked like before the pandemic. But it's now very much more than that. It's a social justice crisis, and I want to unpack that for you a little bit. But first, let's talk about the medical side and why we're so concerned about this, and why it's such a big problem. Um, Basically, so this is in defining the problem. There is this crisis, which I'm sure you've heard about in previous discussions. I define this crisis as in a public health sense. And in public health, we talk about morbidity and mortality, or disability and death. Morbidity being the disability, mortality being death, in this case from suicide. If you look at the numbers, it's pretty stunning that currently measure of disability that we have puts the neuropsychiatric disorders in the United States, not so much in the rest of the world, but in the US, this has become the leading source of disability, largely because these illnesses strike early and they take people out of the workforce. They take them out of uh, the opportunity to really support themselves. So people do become disabled at an early age, and many people continue to be disabled for decades. But it's more than disability. It's death is another really important consequence. Mortality here is partly measured by suicide, and unfortunately, the suicide rate has gone up over the last 3 decades. It's really striking because in the same period of time, so many other of the major medical sources of mortality, like stroke and heart disease, HIV, have all gone down. So this change in suicide is really striking. It's also important to note that the big increase in suicide here in the United States is really out of sync with the rest of the world. Global suicide rates have gone down very significantly since the 90s, at the same time that it's climbed in this country. And even beyond suicide, one of the most important aspects of mortality is the overdose death rate, which is just skyrocketed. It's just incredible to see. It's tenfold increase in mortality in overdose deaths. And this is a graphic reprinted from the New York Times that shows that uh, by the late teens, that had surpassed the peak deaths from car crashes, HIV, gun deaths, all these things. This is like in a whole new world of public health mortality. Up until we got to COVID, we really had nothing new that looked like this. And in fact, even during COVID, we've seen a surge in overdose deaths. So yeah, it's true. With COVID, we're talking about 427,000 deaths now, but overdose deaths this past year were at 81,000, which is just crazy as a number relative to other sources of preventable mortality. Today, we use this term a lot. We talk about deaths of despair, and Ann Case and Angus Deaton, that's a husband and wife team from Princeton who got the Nobel Prize in 2017, have written a lot about deaths of despair. What they mean by that are the deaths that result from suicide, drug overdoses, and alcohol related. And those have, as you can see, they've more than doubled in the past 20 years. And again, kind of really striking because that is sort of unique to the United States. In fact, even before COVID, these deaths of despair had dropped lifespan in the United States for the first time since the influenza pandemic of 1918. So this is really a massive public health issue that we don't talk very much about there hasn't been much focus. And of course, COVID has made all this more complicated. It is where all the attention's going. But at the same time, the pandemic has really pushed the public health crisis of mental health. Huge increase in depression, huge increase, particularly in young people, of suicidal ideation. The economic downturn is expected to have all kinds of consequences for mental health. Sometimes those aren't going to play out immediately, but will play out over the next couple of years. We point a lot to the UN's warning about this, claiming that they think that mental health will become actually the second pandemic, that one of the major consequences of the COVID-19 pandemic will be not just the social consequences, but the ultimate effect on public health, driving up these uh, deaths of despair. And you can see in that third bullet, they're expected in the US to go up by another 20,000 due to the pandemic. So I guess it's important to frame this as not just a crisis, but it's the mental health crisis is a little different than the COVID crisis. It's not like we have an emerging disease all of a sudden. This is a set of problems that have been with us for a long time. What we have is really a care crisis. It's that we're no longer providing the sort of help that people need to be able to recover. And for me, there are sort of three pieces to that I want to just walk you through quickly, because again, this is all in the spirit of saying, what's the problem we need to solve? One of them is that most people who would benefit from care aren't getting it. And there are a bunch of reasons for that, but we will basically call this a lack of engagement. When people do get care, what they get isn't great. It's usually very fragmented, it's often very delayed. It's often in a crisis, which is not the best time to receive help. And then finally, unlike the most of the rest of medicine, there's not the kind of accountability here, what you would expect. There's very little measurement of outcomes. And generally in medicine, just like everything else, you can only manage what you measure. If you don't measure outcomes, you can't improve. You can't get better quality. You can't get the accountability. I want to just quickly drill into each one of these so you can get a real feel for what we're talking about. On the question of sort of access and engagement, it's worth pointing out that there was a time when we did much better on this. Back in the 60s and 70s, and even a little bit in the 80s, there was a system of hospitals, a system of community clinics. There was a lot that we could offer people. That's the blue line, just shows the state hospital beds. The orange line shows the increase in jails and prisons over that same period of time. And the result is that today, as probably many of you have heard, people with these mental illnesses, these are fundamentally brain disorders, they're medical problems. They're far more likely to be found in jails and prisons than in state hospitals, even at like double the number. And they're just about as likely to be homeless or in a kind of a single occupancy hotel someplace in an inner city as they are to be in healthcare. So, huge problem with just having people in the care system. But even beyond that, when you look at this kind of as on a population basis, there are about, I don't know, maybe 10 million people in the United States who would qualify for having what we call serious mental illness. That would be schizophrenia, bipolar illness, severe depression, an illness that's truly disabling, that keeps people from being able to function. So if we say that there are 10 million of those, the extraordinary thing is that, again, about 60% are not in care. So about 40% are receiving services. Of those, only about 40% get services that have actually a scientific basis to them, services that we would say would meet the minimally acceptable standards the way we would in the rest of medicine. And we know that of that group, about a third will do very well, a third get some benefit, and a third don't really respond. I call this the 40-40-30 rule. And the point of it is that we could be doing pretty well down here at this level. We could put a lot more energy into making sure that more people are getting really high quality care. But unless we do something to engage at these upper tiers, we're still working with a tiny population. At this point, you're already down to 16% of the population. So yeah, maybe you can move this from, you know, part of this over. So you go from 5 or 6% to maybe 8 or 10%. But what we ultimately have to do is to figure out how to engage a much higher number. And of course, I'm going to talk to you about why I think technology could be helpful there. Second bullet there was around lack of quality. So the first part was lack of engagement. This is lack of quality. And what I mean by that is several things. First of all, um, mental health care is ridiculously fragmented. So the care of people with serious mental illness is separate from mild to moderate. Mental health is separated from substance use, and everything's separated from the rest of medicine. Huge delay in care. The care system we have is really built for payers and providers. It was never built for patients and families, and it's entirely crisis driven. It's all about taking care of people at their worst moments, not engaging them early so that you can prevent any of that. So this is all about emergency rooms and hospitals, which is not where you're likely to help people recover. A third piece, the lack of accountability. Again, a lot of this has to do with our failure to measure. And again, obviously, I'm teeing you up to talk about what we can do with innovation here. But the way we measure in this field, unlike, let's say, diabetes or hypertension, where we have biomarkers or we have some objective measures, is we just ask people how they're feeling. And we do that in a group of in people who have a group of disorders where by definition their subjective report does not match any objective reality. So that's not really getting the kind of information you need. We do it in the clinic. We do it on occasion, so we don't get a full, comprehensive, continuous picture. And we do it in a way that doesn't really, it's not very convenient. Obviously what we need is measurement that's objective and continuous and ecological and passive. And there are all sorts of opportunities to think about how to do that. So let's move on to the second part of what I want to talk about. So we've talked about the problem in terms of engagement, in terms of quality, in terms of accountability. What about the solutions? What can we do there? Well, it's obvious to anybody in this class that the way that we get goods and services has changed dramatically in the last decade. It's, as you can see here, it's on demand, it's transparent, information rich, it's very consumer focused. Healthcare, either this year or last year, is anything but. Now it's true we've moved more into virtual, so telehealth has replaced the brick and mortar. But for all these other issues, we still have delays, we have very little information, we don't have the transparency. It's entirely reactive, it's not proactive, and all of that is part of what needs to get fixed. So what I want to suggest to you is that if we think about each of those problems that we've just gone through, there are innovative ways to get at each one of them with solutions that with the lack of engagement, we can solve that through person-centered online care. The lack of quality we can do through what technology does really well with digital tools for connection and coordination. And the accountability we can really flip by getting after measurement and providing the kinds of outcomes that people can track. Again, let's just quickly drill into each of these. And this is not meant to be a promo, but just to mention one of the companies I work with that I co-founded called Humanest has just taken a laser-like focus on engagement and said, what if we could create the kind of tools that people really like in the mental health space. So instead of calling in and getting an appointment in 6 weeks, you have a minute clinic that has therapists or clinicians available anytime, day or night. And they're like in a minute clinic. You may not be able to see the same person day after day, but you don't have to go to the emergency room, and you don't have to wait 6 weeks for an appointment. What if you could build something like Peloton, where you actually have a community? You come in as a team, and you work with others to give them support and to get support. Why not think about a different kind of model for the way we engage people so that you give them something they really like. On the quality side, we've begun to learn how to get beyond the simple models of somebody has a psychotic episode, you put them on drug, you have them come back in 6 weeks. We know that doesn't work, that they need a far more comprehensive, coordinated approach. And we built out those models. One's called coordinated specialty care for the first episode of psychosis. There's just no question that we know that that works. On the side of accountability and measurement, I can't stress this enough, and this is maybe the main thing to talk about today, is that you've got to get feedback. You've got to be able to measure. I love this quote from Phil Tetlock that if you don't get feedback, your confidence grows much faster than your accuracy, or as I like to say, your confidence trumps your competence. We need the measures to do that. Now, some of that is easy. You can ask people to fill out a rating form like a PHQ-9 that Michael mentioned before. You just, have them take this 2-minute form. You do it online. You create the, nice kinds of dashboards for patients and clinicians. And a company called Owl Insights has done that really well. People love it. 85% of people will track their progress, helping to know when they're getting better or when they're not. We can do more than that. I mean, today, as all of you know, in the last year, almost all psychiatric care, mental health care has moved online to telehealth. Um, it was about 5% telehealth, 95% brick and mortar last January. And this January, it's exactly the flip of that. It's about 95% digital. What I want you to think about is what we could do with that platform, because what we're doing now really is, it's not just 1.0, it's ridiculously primitive. It's just taking the kinds of treatments that we were offering in the brick and mortar setting and doing it on Zoom. It's hard for me to imagine that as being innovative. But at the same time, we have the opportunity, because people are in this digital space, to collect an enormous amount of information that is getting lost in the process, some of which could be remarkably helpful for managing care. This is a paper that came out in Nature just a little more than a year ago, and I had forgotten about it. I went back to look at it recently. Like we have the genome and the proteome and the phenome. This is the screenome project. The idea that there are scores of factors, of variables that we can pick up from people's screens if we just think carefully about which ones matter and how we might want to do this. This is all sort of part of the quantified self movement, but it has a lot of meaning, a lot of implications for the way that we track how people feel, how they think, how they behave. The term of art, which I think you probably have already heard talked about, is digital phenotyping. And again, phenotyping as opposed to genotyping. Genotyping is genomic sequence. Phenotyping is your behavioral sequence. It's the profile of behaviors that you try to map onto the genome in some cases. But here what I want to suggest is that there is just a range of things we can begin to measure that we haven't been taking into account. Some of them are the sensors that are in a phone. Some of them are like voice and speech measures that are super intriguing. We'll talk more about those in a moment. You can even look at interaction with the keyboard, reaction time, and what measures that we think may be related to executive function. There's this whole field of digital exhaust, looking at social media posts and search terms and all of that. That has to be done with trust. There has to be a way of maintaining privacy and agency and all of that. But the opportunity here is to just extract an enormous number of features that can ultimately give you the kind of picture, that kind of continuous objective picture of how people are thinking, how they're feeling, how they're behaving, that we just so badly need in this field. Again, let's just go a little deeper into each of these, because I think that it's worth talking about what we know and what we need still. On the sensor profiles, if you just think about what's on the phone, you've got measures of activity, which some of them are just, obvious, like sleep and step counts. And you can imagine how those will change when people become manic, or when they, people who have attention deficit hyperactivity disorder. It's built into the name. And yet we haven't been tracking activity or hyperactivity objectively. We can do that, and we should do that. And we should start using this kind of data the way that a primary care doc will use blood pressure or weight or blood glucose to monitor other aspects of health. The GPS is a little more fraught. A lot of people feel very uncomfortable with that. But I put it up here just to remind us that looking at spatial location gives you a lot of interesting information if people want it, to be able to track things like social withdrawal and avoidance, and to be able to understand where are the triggers for something like a panic attack, or someone who has an addiction problem. What are the locations they need to avoid because there are trigger events there. Um, Even just looking at digital exhaust and screen use can teach us a lot about what are people interested in, where are they spending their time, what are they thinking about, are they on conspiracy sites, are they focusing on um, sites about how to tie a noose, or how to what's the lethal dose of a medication. These are really important issues to understand. And then looking at measures of social interaction. Maybe it's text outgoing versus incoming. It's calls outgoing versus incoming. All of that can help you to know when people are becoming either manic or depressed or socially isolated. Language is a really interesting opportunity that has just not been tapped in this area. And for those of you who are interested in natural language processing and AI and other ways of getting at this kind of data, I'll just say that, this is at the very heart of what we do in mental health. The whole mental health field is built around listening to what people say. And to be fair, it's also listening to what they don't say. I mean, but it's all about capturing a sense of what somebody's experiencing by their language, by how they communicate. It's also observing what they do at the same time. So it's looking at face processing and movement and all of that. But language is super interesting because it through NLP, we can begin to get objective measures of things that right now are really kind of subjectively processed. Um, when I was in training, I was always mystified by this. We'd see a patient who had something that the psychiatrist would call thought disorder. And that was like the telltale sign that somebody had a psychotic illness, mania, psychotic depression, schizoaffective illness, schizophrenia. And I had to confess, I never really understood what they were talking about. And when I would say, well, what do you mean by thought disorder? They'd say, well, the person is, incoherent, they're paranoid, they're grandiose, a whole bunch of things like that. And I always wondered, are you're making that judgment based on something you've heard, but isn't there a way to do this that would be more scientific? And I think NLP does this. So you can imagine that in real time, I like to think of this kind of like Waze or Google Maps, creating tools that help a, a nurse or a peer or anybody who's interviewing a psychiatric patient to navigate the interview and to begin to put numbers on these terms, which in fact we can already do. I mean, we know how to measure sentiment or incoherence or the velocity of speech. These are not aspirational. With TensorFlow and with NLP tools, we've been able to do this for years now, but it hasn't yet been converted into a tool that can be used in an emergency room or used in a mental health clinic, or a rural clinic in sub-Saharan Africa, where there are real needs, both global health needs and remote monitoring needs, and all of that. So I think there's a spectacular opportunity here to transform this whole field by taking what is at the core of the field, which is this ability to listen carefully and to understand someone's internal world by hearing what they say and what they don't say, and doing this in a way that's objective by giving us a new set of tools that are really navigation tools, very much like what we would use in the world of navigating traffic. A bunch of companies are working on this now, but I have to say, having um, watched this pretty carefully for the last couple of years, I don't think anybody's really cracked it yet. I think we have a ways to go. So let me summarize what I've just told you, because we're in this solution space still, and I'm like an incredible cheerleader for the idea that digital tools can make a big difference. They can do it in many different places. They can do it with these kind of mobile interventions, like providing psychotherapies or coaching or peer support, or even crisis tools online. They can do it through the way that we manage care. So getting better measurement, getting better data, getting better coordination of care so we can reduce that latency between when people need help and when they get help. And then, excuse me, in the way we've just been talking about, these kinds of digital measures for phenotyping so that we have proactively, continuously much better assessments. And we know when somebody's getting depressed. We know when they're getting suicidal. We know when their psychosis is coming back. We don't have to wait until there's a crisis to intervene. And maybe most importantly, when you look at this kind of an arrangement, you can think of it as a kind of learning engine in the way that we love to do here in Silicon Valley. Everything we build has got these feedback loops so that you always get better. All of the software and every piece of hardware improves every time it's used. That's what we need to be doing here. We need a learning engine that improves mental health outcomes, mental health care. Okay, I just want to quickly go through one other piece, and then I definitely want to open this up and love to hear your thoughts and questions. But this gets into this issue that I've been thinking about a lot recently and still trying to understand, frankly, and that is that the care system we have, which I've said is really broken in lots of ways, in some ways is shooting for the wrong goal. The goal it shoots for is we want to give people medicine or maybe therapy that reduces their symptoms. I think we could do much better. And so there's a movement afoot, and it's partly from people who have struggled through having a serious mental illness. And it's a movement for recovery. It says, look, we're not just about not, having fewer hallucinations. We want to have a life. We want to be able to have a job, have a full and rich life like everybody else. And when you begin to think about this, you kind of move from talking about healthcare to talking about health. I had to confess, for almost my entire career, I thought they were the same thing. I thought the whole point of healthcare was to improve health. And it is, but if you flip that equation the other direction, you realize that health is about a lot of things that have nothing to do with healthcare, right? People who think about this really well now, like some of the people in the health services world, the best estimate, and WHO writes a lot about this, is that clinical care, healthcare represents about 10% of health outcomes. It explains about 10% of the variance of health outcomes. There's lots of other stuff that fits into this, like social and economic factors. Sometimes we say, your zip code is more important than your DNA code. Health behaviors, that it may be more important to know how you live and what you eat and how you exercise. All of that could be more important than the medicines that you take. So as we kind of take a wider lens here, you realize a couple of interesting things. One is that, yes, we should improve care, but you could put a huge amount of energy into care and you still may barely budge on the outcome of health, which is what we really care about. Now, that's important to think about because in the United States, before COVID, we were spending about $3.2 trillion on clinical care, on that 10% piece. That's actually probably way over 3.5 trillion now. It's probably hitting like 20% of our GDP, which is ridiculous. No other country does anything like that. But the more important point is that this other piece, the 70%, the social and economic factors, the health behavior factors, are they're not being funded very much at all. They're being funded by bake sales, by charities, by philanthropy. They're just not considered kind of the hard stuff, the hard science that has driven that $3.2 trillion budget. There are no pharmaceutical companies lobbying for this piece. There are no insurance companies that are covering this. It's not part of the claims world that we all think about as being the driver of healthcare. That's important because if we really do want to bend the curve, if we want to make sure we reduce disability and we reduce the number of deaths of despair, we've got to be thinking about something more. And I define this kind of recovery goal as making sure that we capture these 3 P's: people, place, and purpose. This is super important: people, place, and purpose. And just like to quickly tell you a little bit about each one. And people comes out of this increasing recognition that loneliness is sort of the #1 public health crisis, maybe right behind COVID, that our current and former Surgeon General, Vivek Murthy, has written this really powerful book called Together, which covers the data on why he thinks loneliness is such a critical public health crisis. But it also covers the fact that there are many solutions. They're not in the healthcare setting, but they are solutions that we have access to. There are clubhouses and networks and online groups, like I mentioned, Humanist. I mean, there are lots of things we can do to conquer loneliness if we begin to make the commitment and realize how important this is. So it's people, place, and purpose. On the place side, homelessness is a massive issue here in California. This is the main thing we talk about. When the governor gave his State of the State address last February, the entire address was on homelessness and mental health. That's all he talked about for 65 minutes. This is a big issue for us. And yet here too, we've got these solutions. We've got supportive housing. We know how to create facilities that help people to recover and include sort of long-term planning. If anybody doubted that, you just had to see what happened in the last year during the pandemic, when we developed this thing called Operation Room Key, which just took thousands, tens of thousands of people off the streets and put them into motels and started to give them services. We absolutely know how to do this. We're just not doing it. The last one, the last P, around purpose, super important, again, to make sure that people with mental illness, or for that matter, anyone, has access to the kind of education and employment training that lets them be able to thrive, that lets them actually find a purpose, a mission. And we can do that even for people who have severe mental illness. One of the things that has been fascinating to watch in the last few years is the way in which people with schizophrenia, as they recover, can use that lived experience to help others and to advocate for others. This whole idea of using peers and peer support is revolutionary. And it's not only revolutionary because it expands the workforce and it's helpful to so many, but it's helpful to the peer himself or herself. It's both getting help and giving help at the same time, kind of like what you see with AA, but now we can do that much more broadly. So I'll kind of wind this up by saying that I think we've got a set of problems that are really healthcare problems in a sense. They're medical problems, but the solutions are much more than that. They're social, and they're going to require engagement with these 3 Ps and with engaging families and peers and friends to really make the difference. There are already institutions that are beginning to do this. Again, they exist on a shoestring. They exist through philanthropy, and we need to begin to ask: should healthcare and should innovation tie all this together? So I'll finish up by saying that what we've got is a care crisis. It's not a healthcare system; it's a sick care system that we have today. Late stage, reactive. It's all symptom driven and crisis driven. And what we need is actually a new kind of healthcare system that includes recovery, that moves much earlier to bring people in. Technology is going to be fundamentally important to make that happen. And we begin to think about continuous and preemptive or proactive care, something we haven't done before. Um, that's not to say that we don't need the current sick care system. It needs to be even better. We have to be able to do crisis services, and we need hospital beds, we need clinics, we need all of that. But we need this focus on recovery as well, and we need to be thinking about prevention. How do we move upstream? How do we ensure that every kid in school is getting the kind of resilience training and is able to track and to understand their own behavior and their own changes in mood and sleep and all of that? This is very doable. Okay, last slide. I just want to kind of go through what I've told you. One is that we've got this crisis. It's a crisis of care. We've got solutions for each of the major problems driving that: engagement, quality, and accountability. Um, we have to shift to think about recovery as the goal. And recovery, again, is these three Ps. And maybe the most important shift is to remember that, yes, this is a public health issue, that these are medical problems, but we need to widen the lens to understand that the solutions are much more than medical, that they have to involve those three Ps. And unless we do that, we're never going to be able to bend the curve and make the impact that we need. Innovation, technology, AI, is a huge role in every piece of this. It's going to be critical for doing the integration, doing the coordination, getting the measurement that we need to be able to ensure that people can recover. So I'll stop there, stop sharing as well. Um, Sorry I had to run through so much of that so quickly, but I'd love to get your thoughts about it and have a chance to hear your reactions and your ideas about some of the same issues. Thanks.
Thank you so much, Tom. I was sure that you would not disappoint. It was a great presentation, and I feel sure that this will inspire many of our students to continue doing great work. But so questions now, and we have all kinds of different friends, supervisors here. So let's prioritize the undergrads. So anyone in the program that would like to ask something to Tom, go ahead.
I had a question. So, like I like how you identify and broke down, the crisis, the possible solutions, and also like identifying the social factors that we have to look into also. I guess like one of the biggest question I had is since we identify the problem, we know ways we can approach the solution being like a multifaceted approach with both medical and social implications. What's stopping us from actually achieving or implementing those solutions if we already kind of know the direction we should be going in?
Yeah, Stanley, that's the billion-dollar question. We we really there are a bunch of barriers that get in the way, and almost all of it is fixable. But I think the biggest single thing is the lack of leadership. Um, a little bit it's like what happened with COVID, where we put a huge amount of energy into developing the vaccine, but nobody thought about the program for vaccination. And I think that's where we are at here as well, that we do have good treatments, psychological treatments, medical treatments. We even have neuromodulatory therapies. We have a whole range of cool stuff to offer. We know how to deal with those three Ps. We know what that requires for building social support and having safe places to live. But there's just not been the leadership to make this happen, to think about how to implement and to make a commitment to this. Instead, what you see is people are exasperated by homelessness or by crowding in the jails without understanding that the root cause is this untreated mental illness. And the root cause is the lack of a kind of social safety net that we actually used to have, but it's just been so eroded. So, when I was starting off in my career, this is like right after the late Pleistocene, we didn't, this was in the 1970s and 80s, we didn't have homelessness. People with mental illness with these brain disorders didn't end up in jail. None of this was happening. We had a pretty good system to take care of them, but all of that has eroded over time, and no one's been willing to make the investments. All the investments are going into trying to kind of fix the crisis without actually creating the structures that we need. So, but you asked the right question, is why aren't we just doing this? And what we really are going to need, I think, is a social movement to make it happen. And the last thing I'll say about this is I've actually come a long way. When, like I was saying in response to Mercedes, I started as a basic scientist, and I was really very focused on molecular targets. And I really think of myself today as more of a civil rights advocate. I think of this as a social justice problem that needs a whole social justice movement to fix it. And that's probably what it's going to take.
Thank you, Tom. Anyone else?
Oh, I had a question when you were talking about engagement. I was wondering, because I know a lot of mental illnesses require like 3 months of continued symptoms in order to be diagnosed. Do you think does that contribute at all to the delay in receiving care?
It probably contributes to the delay in getting a diagnosis, but I don't think that a diagnosis is the big barrier to care. It's a little complicated. It's kind of what, in the world I live in, it's what's called a two-sided marketplace. On the one hand, it's sometimes hard to find a therapist or hard to find a provider. A lot of providers don't take insurance, and a lot of within network providers are already booked out, and it can be months before they have an appointment available. So a piece of it is on that side. But I have to say, it's more complicated. I think for a lot of people who struggle with mental illness, the illness itself is a barrier. Many of you have probably not experienced depression, but when you get depressed, it's hard to describe. It's not at all like sadness. It's just total despair. It's this deep sense of hopelessness and helplessness. And when you have that, like, the last thing you're going to do is work hard to find somebody to help you. What's the point? It's the same thing when you're intensely anxious, you're avoidant. And if you're psychotic, you don't think you're sick. So why would you even seek out a diagnosis or a treatment? So this is so different from trying to connect people with heart disease or cancer to care. One of the biggest reasons why we have low engagement is because people don't actually seek it. And so often it's a family member or it's a friend who's trying to drag them into care. And yet we're not open to that. The care system is so focused on privacy, we don't listen to family members. So it's just, there are a lot of issues around engagement that still need to get fixed.
Thank you.
All right, thank you. Anyone else?
I had one question, but I'm not a student, so.
Always. You are very impatient, so.
Awesome. So Tom, really, really awesome talk. I really liked it. So you talked about the task of listening as one of these tool sets of the mental health professional, and you said something that struck me, which is your task is to listen both what the patient is saying and also what the patient is not saying. And I want to pair that idea of the not listening part, which is very interesting to me, with the new role of artificial intelligence and telemedicine and all that stuff. In your perspective, how easy is to assess in telemedicine, let's say human to human, what the patient is not listening versus seeing that person in person? And if it's not possible today, then how do one thing to solve that then with AI in the future?
Yeah, it's a great question. We don't have a lot of data on that yet to compare. There's a company called AI Cure, excuse me, out of New York that was trying to answer that question a little bit. They were trying to triangulate voice, speech, and face, and then comparing digital with real world. And I think it's I think it's still a huge challenge to capture what people aren't telling you. And I'll tell you, like an area where we've been very interested in this is around suicide. We know that most people who, believe it or not, I mean, the people who are truly suicidal usually deny it, right? When you ask them, they'll say no. So is there something could AI help us to identify, is there something in the face? Is there something about the voice? Is there something in the word choice that could help us detect that situation where I mean, and it's a life or death question. Person who's done some great work on this is actually there in Cambridge at Harvard, Matt Nock, who's now I think the chairman of psychology at Harvard. He's really the world's expert. He's been working a lot on sort of implicit association, implicit bias models, and trying to then put the whole thing together, kind of like a whole AI profile that would give you this picture so that we could detect with much greater accuracy who truly is and truly is not suicidal in the emergency room. I don't think we're there yet, but he's getting really close, and he could use the smartest people to help him. It's a great problem. I said that there are 48,000 deaths a year. That's more than all the traffic fatalities. It's more than all the deaths from breast cancer, more than all the deaths from homicide. And imagine that we don't have fundamental tools, really, basic ways of identifying who's at highest risk in the moment. So it's a good problem to go after.
Awesome.
Great. All right, we still have some time, so maybe last question. I know some of you have class at 2, so yeah. Anyone else?
I will open something else for the students. It's Tom. So if one of the students wants to reach out or collaborate, what's the best way for them to potentially do that?
Yeah, so Humanest is an interesting opportunity, and I should tell you that I'm in a bunch of companies. That's the one that I'm focused on most now, but I'm on the board of many, and I sort of have a chance to see this field pretty broadly. And we need good ideas and people with good skills. So best to reach out to me at just tom@humanestcare.com. I think it was the last slide, and Omar, I will share the slides so everybody can have them. But absolutely, yeah, reach out and love to hear your thoughts, and also connect you with some of the companies that are most in need of good data science.
Mercedes, I don't know if you want to add anything.
No, I am in awe. I am speechless. And some of the questions were already made, like when Luis said how you capture what they don't say, or when a patient really lies, either because he's ashamed or because he's not thinking he's lying, So that's the question that already you answered. So, but yeah. Thank you so much.
Well, my pleasure. Thanks for having me. And seems like this has been a great class. And just to go back to Omar's point at the beginning, as somebody who's kind of rooting for this field and trying to make a difference, we need you. We need the smartest, most creative people possible, because the problems are urgent, and we need some solutions.
Yeah, I always tell them that this is not a mathematical theorem we have to prove, but it's a very big problem that requires many minds. So, all right. So thank you so much, students. I hope you enjoy this talk and you are inspired to continue in this field and making contributions. You're very young, so you have all a career in front of you. But we need to inspire you to continue doing great work. Thank you so much.
Thank you, everyone. Bye.
Thank you.
Thank you.
Thank you.
Thank you.